I'm Dr. Steve Parcell, co-owner of NatureMed Integrative Medicine. I'm an expert in preventive cardiology, and today I'd like to talk about cardiovascular risk in women, what can be done, and how they're different from men. I'm going to share my screen here. So, cardiovascular disease remains the main cause of death for U.S. women, accounting for 1 in 4 fatalities. Many patients who die of acute MI have no symptoms prior to the event. Cardiac death remains the leading killer of women at all ages. In fact, death from cardiovascular causes is 1 in 2.6 women versus 1 in 4.6 from cancer. They also die more often prior to hospital arrival compared to men, 52% compared to 42. Part of this is because they have rapidly occurring clustering of risk factors after menopause. They have smaller arteries and get more ischemic changes, and their hearts don't seem to survive clots in vessels as well. Estrogen is important, and when it decreases after menopause, lipids go up, blood pressure goes up, obesity is more common. Also, acute coronary syndrome before menopause is largely from smoking, and smoking has a larger negative impact on a woman's risk compared to men. Younger women with estrogen deficiency have approximately 7 times the risk of coronary artery disease. Estrogen is important because it helps the arteries dilate, which is called flow-mediated dilation. And it's one reason why women don't tend to have high blood pressure compared to men. But after menopause, when the estrogen isn't there, the blood pressure can go up. The plaque is different in women too. So after menopause, the composition of plaque changes from a more stable type of plaque to a more vulnerable type. Also, inflammatory markers go up too. The shape of women changes too. They tend to go from more of a female fat distribution to more of a android pattern. Think of it from going from a pear to an apple, and abdominal obesity, and generally that apple shape where there's weight above the waistline, which is due to visceral fat, is a much bigger risk factor than having excessive amounts of fat below the waist. Women have stiffer arteries compared to men. And this is another reason why they can have blood pressure problems. The estrogen is largely responsible for keeping the arteries more flexible. Estrogen replacement can help, but not after 10 years after menopause. Hypertension is a bigger risk factor in women. Hypertension can make complaints of menopause worse and can include chest pain, headaches, hot flashes, palpitations. And when hypertension is treated, these symptoms can improve. So changes to lipids happen too. After menopause, lipids increase, but in women in general, they have lower lipids than men. Lipoprotein A is a damaging LDL particle that can go up when estrogen declines. Women tend to have higher HDL, but when HDL is low, their risk is higher. So the disproportionate cardiovascular risks in women compared to men include diabetes, increased cardiovascular mortality, not surviving their first heart attack, increased risk of heart failure out of proportion compared to men, more coronary microvascular dysfunction, blood clotting problems, and metabolic syndrome. Coronary microvascular dysfunction means that the small vessels are constricted as opposed to, say, the medium and the large ones. And this can drive up blood pressure. Also, the areas of the heart that are perfused by those small vessels doesn't get oxygen. More hypertension, and it's a bigger problem. More obesity, and it's more of an independent risk factor. So not only is there more obesity in women after menopause, but it's a worse risk factor. So these are some of the risk factors that lead to arterial stiffness in males compared to females. In men, the main driver is aging, high blood pressure, obesity, and metabolic syndrome. But in women, they have different risk factors: preeclampsia, polycystic ovarian syndrome, endometriosis, and autoimmune conditions. Women present differently too, clinically. Women typically get less invasive testing and less aggressive treatment because of this. They have atypical signs of heart attack. However, women diagnosed with non-cardiac chest pain can have up to double the risk of developing ischemic heart failure and acute coronary syndrome, which is also known as a heart attack, in the next 5 to 7 years. So in other words, a lot of women go to the hospital with chest pain, but because they fail or the conventional workup does not show that there's a blockage, they are discharged. Women are more likely to experience chest pain without identifiable obstructive coronary artery disease due to this microvascular dysfunction. They have a higher prevalence of small vessel disease. The plaque looks different too. In women, the plaques are eroded, meaning there's little erosions on them, making them more dangerous. And there's less cholesterol in those plaques and less calcium too. They tend to have less obstruction and more diffuse arterial disease as compared to men. Women also have different vascular biological factors at play. Women tend to have smaller plaques and slower progression, smaller arteries in general, less collateral circulation. Collateral circulation is when arteries talk to each other by growing small arteries to bypass flow limitations. They have less coronary flow reserve, stiffer arteries, and differences in how plaques grow and are remodeled. These are really big differences, and it's one reason why it gets missed in the hospital. And the hospital training really is still catching up to the differences that in how women present. Women have more, they're often have atypical angina. This is, it's pain or discomfort in the chest, but also the arms, jaw, neck, stomach, and behind and between the scapulas and the back. Women more often will experience fatigue, anxiety, cold sweats, shortness of breath, dyspepsia, which is like heartburn, and nausea. Sometimes the only symptom in a female is fatigue. Okay, who knows that? Another cause of chest pain in a younger woman is something called, it's called an arterial dissection, SCAD. And briefly, this is a cause of chest pain in women. It's more common in women than men. And it can be completely missed because the only way to see it is with is doing an MRI, a cardiac MRI. And it's not coronary artery disease. It's not from plaque. It's due to tear in the artery wall. Calcium scoring can be different too in women. Um, Calcium scoring also is it's worth doing after, honestly, in women, they usually don't have anything until they're 50, but it's a very inexpensive test to get. And if there's plaque present, then it's a wake-up call. As I said before, women have more vulnerable, soft, non-calcified, diffuse plaque that is not identified as well with calcium scoring. Women tend to have more diffuse disease affecting smaller vessels that is often non-obstructive. Better candidates for a cardiac MRI or a coronary CT angiogram. In women of all ages, calcium scores are typically lower than men. So in summary, women have more coronary microvascular dysfunction, vasospasm, which is a spasm of the muscular wall of the artery, which decreases blood flow, increased cardiac pain, sensitivity, plaque erosions, and this arterial dissection I talked about. They are more likely to experience stress-related pain syndromes, vasoconstriction, and microvascular dysfunction during stress, with resulting ischemia, and symptoms are more pronounced among women. So when arteries constrict and there's a resulting decreased blood flow to the heart, men and women both get this, but when men have it, they have more pronounced symptoms. Women have higher rates of cardiac-related exercise intolerance and decreased quality of life and fatigue, but a lower prevalence of obstructive disease as seen on traditional angiography. That's when the catheter and the dye goes in and the x-ray, and you can see blockages in the artery. Chest pain in women should be taken seriously and given a complete workup. I think that's probably the most important thing, and understanding that different imaging might be needed in a woman, and to take hypertension even more seriously than you would in a man. The coronary vessels are smaller and contain the more diffuse plaque. Hormone replacement data is mixed, but the general agreement is that estradiol started earlier rather than later has a protective effect. And using bioidentical estrogen is more physiologically natural than Premarin, which is horse-derived estrogen. Progestins, which are synthetic progesterone, do not seem to help with cardiovascular risk, but can protect the uterus. Benefits for menopausal symptoms and cardiovascular risk must also be discussed. Okay, I think that's enough for now. These are all cases. Thanks for listening. I'll see you next time.